വരും.
അല്ലല്ല, ഞാനാണ് ഫസ്റ്റ്.
അപ്പൊ മനസ്സിലായില്ല. അപ്പൊ ഞാൻ എന്തിനാ തുടങ്ങണേ?
നീ ജസ്റ്റ് ഇങ്ങനെ 2 സ്പീക്കർ ഉണ്ട്, ടോപ്പിക് ഉണ്ട്, അങ്ങനെയൊക്കെ പറഞ്ഞ് തുടങ്ങുമ്പോഴേക്കും ഞാൻ വന്നോളൂ. ഓക്കെ അല്ലേ?
ഓക്കെ.
You are only introducing.
തുടങ്ങിയോ സർ?
Yes. Broadcasting. പറയാൻ പറ്റട്ടെ ആൾക്കാരെ to let the people in.
Yeah, okay.
ഷെയറിംഗ് ഓഫ് ചെയ്യേണ്ടി വരെ.
Sir, we'll start in 1 minute. We'll start.
Okay.
Dr. Anoop. All right. Okay.
Hello.
Yeah, we'll start. Dr. Anoop.
Hello.
Yeah, let's start. Good evening, friends. So today we have two very well-known speakers. One is Dr. Anoop Kumar. You all know about him. He's the Chief of Critical Care, Baby Memorial Hospital, and he's given daily updates. I don't have to introduce him. The second speaker is again well-known speaker. He is Dr. V G Pradeep Kumar. He's ex-IMA State President, Kerala. He's currently TCMC Vice President and then Secretary for Indian Stroke Association. He's a neurologist. He's a senior neurologist in Baby Memorial Hospital. He's going to talk to you regarding the neurological manifestation. Before that, we have Dr. Anoop Kumar. He'll be talking on the COVID updates. Over to you, Anoop.
Uh, so today I'll be just giving you an overview about the updates happening. I will not take much time. So today's figure, we are almost reaching 1 lakh, 20 lakhs today. It's almost reaching 20 lakhs with more than 1 lakh 10,000 death. And the US cases reached almost 6 lakhs, Spain 1 lakh 74,000, Italy 1 lakh 62,000, and France 1 lakh 43,000. And Germany has also reached 1 lakh 32. Now the UK is also nearing 1 lakh, the same way Iran also. Iran, but contain the disease in a reasonably good way right now. In India, the cases has increased to almost 11,625, with Maharashtra reaching almost 2,600, Delhi 1,500, Tamil Nadu 1,200, Rajasthan has also crossed the 1,000. Now Madhya Pradesh, Gujarat, all the places are the cases increasing. There is really an outbreak happening in Gujarat, and they are not able to contain the disease. That is reports coming now. In Kerala, we have almost contained the disease with a reasonably good control. You can see we have almost plateaued the line. And this is the other figure. We can see the active cases are really decreasing, and the confirmed cases are also plateauing. We have 386 cases. The evening report I have not taken. So with yesterday's 8 cases, total 386 patients here, with 173 active, and 264 patients are imported patients, and only 122 from that, the expected numbers have not reached. 211 cleared, only 2 death, and we have almost 1,07,000 people in quarantine, and out of that, 500 in hospital. Nizamuddin belt, we have 18 confirmed patients and total 130 patients returned. So this is an important diagram, and this is one issue we have to discuss, because you can see there are countries who have already tested more than 50,000 per million population, you can see. And the other countries 25,000 to 50,000, 10,000 to 25,000, and others are 5,000 to 10,000. So on an average, 5,000 to 10,000 is happening everywhere. See, but in India, we are almost 130 per million tests per million population. And even in Kerala also, we have reached only 200 per million. So definitely we will have to increase the testing. These are the places where there is more than 20,000 per million. The Faroe Islands and all, they have tested 1,12,000 per million population. And Switzerland and all 22,000. So at least we will have to target somewhere around 5,000 to 10,000. So this is just to clarify the present discussions going on about the increased incubation period. This is from the the first papers. You can see the fever onset is continuing. The cough is persisting all the patients, but see the RNA positivity in survivors from day 1 to it is almost lasting up to this area, and in non-survivors also from day 1 to day 19. And incubation period means from the point of contact to the symptom onset. If you don't have a symptom, you cannot say what is the incubation period, and you cannot compare it with the days of illness or days of viremia. So even if you test a viremia and it is coming positive, you cannot say that the incubation period has increased. So this is the D dimer and other lymphocyte count, etc. If the D dimer is increasing and the lymphocyte count is going down, the chances of the severe illness is more. The same way, if the IL-6 values are increasing towards the end, ferritin is increasing towards the end, the chances of dying will be more. The same is applicable with the cardiac troponin I and the lactate dehydrogenase. This red is all for the patient who has not survived. So these markers are really important when you are treating a sick patient. So to clear that incubation part once again, you can see a primary case here. It is like he is exposed, he is having a symptom onset here. Okay, and in first scenario, again he is developing the second infection. The second person is getting infected at this point, and the symptom onset. So second person getting exposed, developing symptom is called a serial interval. And here again you can see before the symptom onset itself, the primary case is becoming infectious. So this is very important. So even if you are testing at some other point of time, it is very clear that you are not testing the incubation period. So in SARS-CoV-1, the patient was not having the pre-symptomatic spread, but influenza had a pre-symptomatic spread. Like before developing the symptoms only, they were spreading the disease. So you should be very careful about that. This diagram we have discussed many times, but again, once again, 30% of the patients with asymptomatic, they can also be infectious for some time. The mild symptoms will be having infectious, like the duration will be more. Patients with severe symptoms continue to be the viremic for a quite long time. So the same thing again, there is a viral response initially, which is declining, then followed by a host inflammatory response. So that will be again increasing. The same way you have other, the viremic phase also increasing. So this is the way the case is progressing, and your symptoms, everything also will be different in all these situations, like your troponin I, the counts, everything will be different. So this is the situation usually. This diagram is very important. You can see the light blue part is a pre-symptomatic spread. So you should be very careful about the pre-symptomatic spread. So there can be a pre-symptomatic spread followed by the symptomatic spread, and the asymptomatic spread is very, very minimal. So you don't have to worry about the asymptomatic spread too much, but the other case you will have to see. And again, the viral, this is the viremic count, which we've already told. The CT value, when it is high, the viremia will be low. So here you can see the nasopharyngeal swab is having high viremia, but as the disease advances, the viremia will be decreasing, or the CT value will be going high. This is again with the viral load. In the severe disease, you will be having high viral load, but in mild disease, the viral load will be minimal. This is again indicating the same diagram. And today, in all the media, there was an issue saying that the Tamil Nadu, the death is because of hypoxemia. There is nothing new. Any patient with a respiratory illness will be having hypoxemia. That is why all the patients should be tested with this pulsoximeter. It is very easy to check you the saturation. This is a non-rebreathing mask where you should be you should be used in all the COVID hospitals. So this is a just initial short view, and now we will be having an excellent presentation by Dr. Pradeep. So he will be discussing in detail about the neurological pictures.
Thank you, Dr. Fabid and Dr. Anoop, for this opportunity. And good evening, one and all. Neurological manifestations are one of the important scenarios or condition state where the patient will have some fatal outcome. COVID-19 has got very limited neurological manifestation described so far. Since it has been described, only 4 or 5 papers have came so far in various journals. But studies are going on, and after some time, probably within few weeks, we will have more of information about this. You all know about these COVID-19 symptoms. They resemble almost like SARS coronavirus, who shared same receptor, angiotensin converting enzyme 2. And the clinical manifestations are predominantly respiratory symptoms, apart from the prodromal symptoms like fever, myalgia, and fatigue, and can cause multiple system involvement with clinical severity. And when they involve the respiratory symptoms, that cause high mortality. And neurological manifestation also has found to cause high mortality at some times. And the basic pathogenesis, you all know, it is due to involvement of the angiotensin converting enzyme 2 receptor. And for entry into cell, this virus using the spikes protein, they enter into the ACE2 receptors, and they are expressed in various parts of the body like airway epithelia, lung parenchyma, vascular endothelium, kidney cells, and small intestinal cells. They are also expressed in some part of the neuronal populations like cardiorespiratory centers in the brainstem and median raphe nucleus, hypothalamus, and motor cortex. Predominantly involvement of the brainstem like respiratory center involvement has been attributed for the respiratory depression. That is why many people even while on ventilator. Apart from the other reasons, they have been postulated that because of the central respiratory involvement is one of the factors which has been found to cause severe hypoxemia. And they may gain access to central nervous system through the olfactory receptor nucleus, which has just as herpes virus also access to the brain and spreading to the olfactory bulbs and then to other parts of the brain via transsynaptic transfer. For example, they can spread it to the thalamus, hypothalamus, brainstem, and medial temporal lobe. The medullary cardiorespiratory centers appear to be highly infected, which may play a very important role in the central respiratory failure. And that is why many people do not respond even to ventilator support. And the coronavirus infects both neurons and glia, and the neuroinfection, along with other systemic inflammatory response, leads to a breakdown of the blood-brain barrier, edema, and the activation of microglia and astroglia. And everything, this entire pathogenesis is due to a cytokine storm, which is a hallmark of coronavirus CoV-2 disease. And the main mediator is interleukin-6, which play an important role in this entire pathogenesis. The major clinical features develop secondary to the hypoxemia, and they deteriorate very quickly. Going from this, people may require oxygen supplementation to oxygen high flow nasal cannula to intubation within a few hours. Some people present the gastrointestinal symptoms like diarrhea and abdominal cramps. Tachycardia, hypotension due to myocarditis has also been described. And elevation of several serum inflammatory markers like interleukin-6, ferritin, LDH, C-reactive protein, D-dimer, and triglycerides all indicate the presence of a potent cytokine storm and secondary hemophagocytic lymphohistiocytosis. This is a hallmark of CoV-2 disease, hemophagocytic lymphohistiocytosis. The neurological manifestations can be categorized to three main areas. One is central nervous system symptoms or disease. Second one is peripheral nervous system symptoms or disease. And third, muscular symptoms. Coming to central nervous system syndromes, they have dizziness and headache, which can happen even the initial state itself. Along with fever, myalgia, they can have headache, and they walk, they feel a dizzy feeling, they have dizzy feeling. And the major manifestations include ischemic and hemorrhagic strokes. They may result in impaired consciousness or altered sensorium. They may present as muscle injury, where more prevalent in patients with more of severe respiratory disease. Since elderly patients with chronic medical conditions are not, they are always at an increased risk of altered mental status in the setting of acute infections. Patients with COVID-19 infection can also present with acute encephalopathy and changes in the level of consciousness. So encephalopathy or altered sensorium is one of the predominant feature, a common feature, which have been described in CoV-2 disease or COVID-19 illness. Reports from China, there is a publication which has reported 3 cases of ischemic stroke involving various territories associated with positive antiphospholipid antibody syndrome. So there is a secondary reactivation of the antiphospholipid antibodies, which has been found to result in stroke like ischemic strokes. And there rise the possibilities of role of COVID-19 infection related to antiphospholipid antibody syndrome, the pathogenesis of thrombotic stroke. 5% has been found to develop stroke in the present so far studies, and more papers have to come from the Europe as well as from America. They are more associated with severe disease, and they involve more the older population with associated comorbid risk factors like diabetes, hypertension, hypertriglyceridemia, coronary artery disease, and many of these patients have found to have severe pneumonia. Mechanism of the stroke include hypercoagulability secondary to maybe dehydration or septicemia or due to cytokine storm. The cardioembolism, which is secondary to myocarditis also in these patients. Direct role of viral infection like vasculitis, just as can occur with herpes infection and other infections. D-dimer elevation can produce thrombotic episodes. Thrombocytopenia can result in hemorrhage, and increased creatine kinase level has been noticed in this patient. Patients with acute stroke needs to be treated as an emergency, even in this pandemic. So all patients, we cannot leave away because of COVID pandemic, we cannot leave away the acute stroke, we have to treat these patients. All patients with acute stroke who are COVID suspect or COVID positive needs to be managed in COVID designated areas. So whoever is coming with the COVID positive, already treatment for COVID infection develops an acute stroke, they have to be managed in the designated area for COVID patients. And imaging, CT scan imaging is preferred because MRI has to be minimized. Many hospitals only single MRI, which cannot be designated. If you have 2 CT scans in hospital, 1 CT scan should be specifically designated for COVID patients or COVID positive or COVID suspect patient. And in ischemic stroke, CT angiogram should be done if possible. And because to identify small vessel disease or large vessel occlusion. It is advisable to do a CT test in COVID positive patients along with CT head. So whenever the patient comes to ED after triage, before taking the patient to the CT scan, you should inform the staff in the radiology in advance that such a patient will be shifted, so that the staff there can have adequate precautions like PPE, gloves, mask, and goggles, all the precautions which are required for a COVID patient. So surgical masks should be given for all non-intubated patients. If the patient has been diagnosed with an acute ischemic stroke, intravenous thrombolysis follows the American Heart Association guideline for intravenous thrombolysis. In a COVID positive patient, it may be advisable to get a platelet count before IV thrombolysis, because if the patient has thrombocytopenia, then there is chance for hemorrhage. And before shifting to the COVID ward, we should have a platelet count done. Very frequent monitoring may not be required if adequate persons are available, not available. For example, after IV thrombolysis, you have to monitor the patient every 15 minutes. So the frequency may be a little reduced in this patient, but still, if the patient is very sick, you have to monitor very frequently. If COVID suspect, keep the patient in isolation till test results are available. If the patient has a large vessel occlusion in a COVID positive status, how do you go with endovascular thrombectomy or mechanical thrombectomy? All the staff should have a separate angio suite, and patient should be given all the precautions should be taken, and then if a mask for patient should be given, elective intubation prior to shifting to cath lab. If high score, National Institute of Health stroke scale score, high score severity, stroke severity, drowsy patients, and vertebra-based patient, you should intubate, and limited staff for the procedure should be used, and all staff should be with full protection of personal protection equipments, and entire protocol has to be followed for all the COVID positive care, and the extubation should be done only in designated area with the minimal staff assisting the extubation procedure. And stroke unit care, stroke unit is an area where the stroke patient is treated with the designated staff and physiotherapist and the rehab people and the treating stroke physician. Treatment in designated areas for COVID positive and COVID suspect patients. And in ischemic stroke patients, the high D-dimer level, preventive anticoagulation is recommended to prevent further thrombotic episodes. In patients with stroke and hypertension, blood pressure fluctuations are seen following COVID infection. And in patients on angiotensin converting enzyme inhibitor, like enalapril and the other group of drug, or angiotensin receptor blockade, ARB, like losartan and irbesartan, it is suggested to consider calcium channel blocker or diuretics. This is a pathway for the stroke care pathway. If a patient has got an acute stroke, the coming to emergency department, if the patient is not a COVID-19 suspect patient, then the standard stroke care, acute stroke care should be given. If the patient is a COVID positive patient, then the patient, if the hotspot, we have the mobile CT if possible, but it's not possible in our setup, we should have a designated CT scan, or we should priorly inform the CT people or the radiology people that such a patient be shifted. And after the CT scan is done, the entire area has to be fumigated. If the CT and CT angiogram in a COVID positive patient shows large vessel occlusion, patient can be taken up for cath lab, designated cath lab under general anesthesia, should be mechanical thrombectomy should be done and should be shifted to special ICU dedicated for stroke and COVID-19 patients. If the patient does not have a large vessel occlusion in COVID positive scenario, they should be going to dedicated COVID-19 medical ward, and acute stroke treatment should be continued. If the patient is a COVID-19 suspected patient, and if the patient has got coming from the hotspot, you do a fast track nasopharyngeal swab, and then after that, you take the patient for mobile CT angiogram, then subsequently again large vessel occlusion taken up for angiogram, mechanical thrombectomy in a cath lab, and in the COVID, by the time the result comes, if it's COVID-19 screening is positive, shift the patient after the COVID-19 medical ward. If it is negative, then the patient should be considered to stroke unit. So this is the algorithm of managing acute stroke care pathway in a COVID setting. The other manifestation is the meningoencephalitis. A group of people from Japan has reported the first case of CSF-proven SARS-CoV-2 meningoencephalitis. It's a 24-year-old gentleman presented with new onset, late onset seizures and altered sense of consciousness, preceded by an 8-day history of fever, malaise, and sore throat. CSF PCR was positive for SARS-CoV-2, while nasopharyngeal swab was negative. So CSF showing a positivity in the CoV-2, SARS-CoV-2 as a COVID-19 infection. So MRI showed evidence of restricted diffusion along the wall of the inferior horn of right lateral ventricle and hyperintense signal involving right mesial temporal structure. Henry Ford's Hospital Radiology Department has published the first reported case of acute hemorrhagic necrotic encephalopathy. This is another manifestation, meningoencephalitis manifestation or secondary CNS manifestation of COVID-19, necrotizing encephalopathy. 58-year-old female presented with altered mental status in addition to upper respiratory infection symptoms. And CT scan, non-contrast CT showed bithalamic hypoactinic lesions. MRI revealed hyperintense signal with internal hemorrhage in the bilateral thalami and medial temporal lobes. I will show you the pictures. Right. The other symptoms may be hypogeusia, loss of taste, loss of smell, and neuralgic pain. And the Lancet Neurology has described the first case of Guillain-Barré syndrome in a COVID-19 patient, a 61-year-old female patient from Wuhan, presented with ascending bilateral lower extremity weakness without fever or respiratory symptoms, GI symptoms. Lumbar puncture showed elevated protein normal cells, classical albuminocytologic dissociation, which will occur in Guillain-Barré syndrome. And electromyogram nerve conduction study shows absent FAs, proximal conduction abnormality. All these findings are consistent with the early findings of Guillain-Barré syndrome, and these patients they recovered with treatment. Laboratory findings in CNS man symptoms include lower lymphocytes and platelets count and high blood urea nitrogen levels sometimes. There were no characteristic laboratory findings in patients with peripheral nervous system symptoms. Patients with muscle injury had higher neutrophil counts, lower lymphocyte count, higher C-reactive protein and D-dimer levels, as well as evidence of multi-organ dysfunction. Some people have elevated creatine kinase as well. No specific neuroimaging or electrophysiological characteristics are described in COVID-19 patients. These are the MRI findings which you can see in the patients with bilateral thalamic lesions with internal hemorrhage. This is a CT scan which I described the patient had bilateral hypotensity secondary to the meningoencephalitis after COVID-19. You can see the involvement of the medial temporal lobe here, bilateral medial temporal lobe due to hyperintensity in both this imaging, and you can see there is a small hemorrhages into the bilateral thalamus, signal changes, necrotizing encephalitis. So to conclude, that mainly the predominant manifestations of the central nervous neurological manifestation of COVID-19 include peripheral nerve involvement like Guillain-Barré syndrome, myalgia and severe muscle pain, muscle cramps, and third one is the loss of, apart from the loss of smell and taste, patient can have present acute stroke, ischemic stroke secondary to thrombotic episode, maybe due to D-dimer, high D-dimer, antiphospholipid antibody activation, or hemorrhage stroke secondary to thrombocytopenia, or this patient can present with necrotic sensing and encephalitis with hemorrhage and signal changes in bilateral thalamus, medial temporal lobe, as well as various parts of cortex, or they can present with altered sense of limb and only encephalopathy with seizures. So the picture is still evolving. More manifestation may be reported later after this pandemic is over. And neurological manifestations appear to be uncommon, may include stroke, meningoencephalitis, myalgia, and Guillain-Barré syndrome. Loss of taste, hypogeusia, and loss of smell, hyposmia may be common in early symptoms. And we have to take all necessary measures or precautions in treating patients with any neurologic symptoms who are COVID positive or COVID suspect. All the personal protection equipment should be used by the entire health profession, starting from the triage area, emergency physician, up to the neurologist, stroke physician, cath lab people, entire nursing staff, and paramedics. Thank you for the patient listening.
Saji sir? All right, so if you have some questions, you can type here. No questions yet. So no questions. You have some doubts or questions, please. We'll wait for one more minute. So if you have some questions related to neurological manifestation of COVID, you can type here. I think everybody's clear about it. Huh? I think that's it. Okay. All right.
So thank you very much.
Oh, there's a question. Neurological manifestation more common in any age group? Is there any age group?
These neurological manifestations are more common in elderly population compared to younger population, more than 65 years of age, because they have other comorbid factors like diabetes, hypertension, which are prone for any ischemic stroke.
Okay. One second. All right. Okay.
So neurological manifestations are more common in elderly population because they have got the chance of developing stroke, especially with comorbid risk factors and hypertension, coronary artery disease. So elderly populations are more at risk for neurological manifestations.
Any more questions? Okay. Thank you.
Okay, thank you. Thank you.
Okay. I thank Dr. V G Pradeep Kumar sir for such a wonderful talk. Now, that's for